Good
Hello.
evening, everyone. My name is Hetero, and I'm working as a senior manager in the Medical Services Department of Hetero Healthcare. On the behalf of Hetero Healthcare, I would like to invite you all to this third ever webinar on HIV and aging. Before we proceed with the scientific agenda, I would like to take this opportunity to brief you on Hetero Healthcare, which has been a strong partner with HIV experts across the globe. We mark more than 25 years of our journey in HIV management. It started with the beginning of manufacturing and exporting of APIs and finished formulation of antiretroviral drugs. Today, Hetero supplies one third of the global requirement of antiretrovirals. Apart from HIV, Hetero was majorly involved in tackling the national emergencies such as swine flu in the year 2005 and latest COVID-19 epidemic. We have been the principal supplier of oseltamivir to the government, and we were the first company to introduce remdesivir and molnupiravir in India. This was possible only due to strong R&D team and state-of-art manufacturing facilities that ensured seamless supplies of medicine. This journey would not have been so fruitful without your support and blessings. As we know that the life expectancy of people with HIV has increased due to improved efficacy of highly active antiretroviral therapy. The Centers of Disease Control and Prevention has estimated that 50% of people who are living with HIV are older than 50 years. So now the true priority is to focus on prioritizing the quality of life, physical, mental, and functional status of patients who are long-term survivors of HIV and older adults with HIV having multiple comorbid conditions such as cardiovascular disease, hypertension, diabetes, and cancer. To discuss this further in detail, I would like to invite one of the eminent doctor of India, Dr. Ishwar Gilada, to moderate the today's panel discussion on HIV and aging. Dr. Gilada is the first person to raise the alarm against AIDS in India in the year 1985. Dr. Gilada is globally acclaimed HIV expert. Dr. Gilada is a HIV and sexually transmitted disease consultant at Unison Medicare and Research Center at Mumbai. He is the president of AIDS Society of India. He has also been elected as governing council member of International AIDS Society. He is also the Secretary General of People's Health Organization India, as well as Organized Medicine Academic Guild, that is OMAG, which is a national federal body representing 20 professional medical associations. He is actively involved in prevention, control, and management of HIV/AIDS since 1985. With this brief introduction, I would like to take this opportunity to hand over this session to you, Dr. Gilada. Over to you, sir. Thank you so much.
Thank you very much, Hetal, for this introduction.
Thank you, sir.
I thank Hetero Healthcare for conducting this kind of workshop. 1 minute, I'll just this workshop. And when I first read about it, long-term survivors, I thought they're conducting a workshop for those of us who are long-term survivors in the field of HIV. At least me, I can look at Atul. Prakash Bora is senior to me in age. Milind, though Milind has made his hairs look black, but he is old. So, and Manoj, who is growing up with HIV. So basically, this is a unique panel of doctors who are working in the field of HIV for many years, barring, I think, Neha. All of us have been in the field for 20, 25, 30, 35 years. And Manoj, I've been knowing him for at least 20 plus years. So he's, despite having HIV, he's carrying on and very well manage himself. And Hetero, as we just learned, 25 years completed in the field of pharmaceutical company and 20 years in the field of HIV medicine. So all of us would like to discuss both aging with HIV, when people are having HIV and they're aging, and for us, we are aging with the pandemic, and we don't know when we'll fade away, but this part of the whole system. Now, when we started HIV caring in 85 or 86, our first case was in 86, and our sizable number of cases started coming only from 88, 89 onwards. And at that time, we used to know that a person with HIV diagnosis, they die within a year or 2 years. And at that time, 5-year national program of government was famous everywhere. So we used to tell people when they used to come that you plan for your 5 years journey. And in 5 years, whatever you want to achieve, you try to achieve. And they used to say, sir, मेरे माँ बाप को बद्रीनाथ भेजना है, भेज दो जल्दी. Don't wait for 5 years. I have not saved anything for my children. They are growing up. Save something for children. They used to say that I never talked to my wife properly. Start talking properly. So all these things we used to say, and that time we had no ART. We were managing the symptoms. We were managing the diseases like tuberculosis or PCP pneumonia. Hardly we knew earlier what was the treatment. Thereafter, we knew that cotrimoxazole works. At that time, pentamidine was one of the magic drug, and it was not available in India. So in that kind of situation, when we manage patient coming back after 5 years, sir, 5 साल हो गए, अभी क्या करना है? So we used to say make another 5-year plan. So second 5-year plan, third year 5-year plan. We have today patients, at least in my practice, surviving from 1991 till today. There are patients which are born before 1990 and they were detected only at the age of 28 or 29. Without any intervention, they carried on and they can carry on further. So what we can tell today to all HIV positive people, that 4 things are possible. Number 1, if Indian age at birth is around 69 for male, 71 for female, you will live that much of age. You may not die of HIV, you may die of accident, you may die of other things. Number 2, within 3 to 4 months time, we will provide you such drugs that you will become undetectable. Undetectable is untransmittable. So if till today you have not transmitted infection to your spouse, wife, partner, you will not transmit. Number 3, you can bear a child, you can have a child which is HIV negative. Number 4, you will not be hospitalized. Today I can say that out of my 6,500 odd patients, maybe 1,000 are dead already, 1,500 are dead. None of the patient is in hospital. So for this, we bow down before the pharma companies, which made robust molecules, not only robust molecules, but they made molecules which are affordable. Hetero is one of them. And any medicine which is available internationally for $100, the lowest quoted cost in India is $0.7. That is 0.7% of international cost with 100% bioequivalence and reaching out to almost 82%, 85% of the HIV positive community all over the world. Though we talk Make in India now, but this Make in India started 10, 15, 20 years back. And now people started respecting Make in India, so much so that any international pharmaceutical company, they're making any product, they are so scared of India. They come to India, they approach 10, 12 agents, companies including Hetero. They tell them, we'll give you voluntary license. Please manufacture here, sell to Africa or poorer countries, but don't come to our countries. Don't come to any international conference. Don't come to any exhibition, and you can do that. At least we are able to serve poor communities, poor people, both in India and abroad. I think we have done a lot. And to hear this in a more systematic way, we have our speaker, Dr. Atul Gogia. He is from Delhi and he's going to speak. May I have his slide, please? He's a professor at GRIP, which is a postgraduate medical institute and research, senior consultant, internal medicine and infectious diseases, Sir Gangaram Hospital, New Delhi. He's member of Royal College of Physicians, UK. He's MSc in infectious diseases, University of London. Certificate course in HIV and trained in infectious disease. He's co-PI of AMSP ICMR research project. Member of HICC. Reviewer of many national and international journals and more than 110 publications and author of various medical and patient awareness books. Over to you, Dr. Gogia. And I really thank Manoj is here. Just recently, Manoj had conducted a program for the community of HIV positive people and same issues, long-term survivors and what are the issues. So over to you, Atul.
Thank you so much. A very warm good evening from Delhi. We are 45 degrees plus. It's really warm here. And I am really envying Dr. Gilada sir for wearing a coat, because I'm not able to wear it despite being sitting in an
Oh,
air conditioned room.
the Mumbai weather is pleasant, very pleasant. We can
Yes,
send
I
weather
got to know
from
it's
here to you.
raining and it's good there. So it is always a pleasure to have on board with the pioneers. Dr. Gilada sir, we have always looked up to you, and how you just told us the story without drugs, how you managed. It is actually amazing, because we started our practice when we started having a lot of drugs, and now we have so many drugs to choose from. So it is actually, we are blessed actually, because of companies like Hetero, who have got all these drugs. So thanks, and hello to all, Dr. Neha, Dr. Bora, Dr. Milind, and all. I'll just share my screen, and would just be try to make it uh, as brief as possible. So is my screen visible?
Yes, yes.
Yeah. Okay. So, as Dr. Gilada rightly said, we all have been aging with HIV. So, it's about our journey as well as the HIV journey. And we have seen patients now living near normal lives. And so, why we are having this webinar, probably it's the HIV long term survivor day, which was celebrated on a week back. And it is just a continuation of that, probably, which has led us to be having this kind of a webinar. We are discussing things which are beyond HIV. And thanks to effective HIV treatment, as we see, number of older adults living with HIV is ever increasing. So the number is increasing. We are getting patients who are 50, 60, 70, and they are, it's rightly highlighted by Dr. Gilada that it is the comorbid illnesses which is causing more of an issue rather than HIV per se, because of the kind of drugs. So I'm just going to be talking about aging and HIV, the comorbidities, prevention and care challenges, aging, alcohol use, and HIV. Just dividing it so that we can touch upon certain things. And I think it would be a great thing to have a panel discussion where we'll have a flavor of the young to not so young who have traveled with HIV, discussing afterwards. So, 50 is actually not old, but for HIV, we are considering 50 is old because HIV may accelerate the aging process. That is what the concept is. There is onset of age-related diseases at an earlier age, and whole lot of non-AIDS comorbidities that we've been saying, like diabetes, coronary heart disease, depression, non-AIDS cancer, etc., are coming up, and there is complex cases of cognitive impairment because of long-term HIV. So, as we all understand, just a description of prevalence of HIV infected people above the age of 50 is rapidly increasing, as we know, because of the effective treatment. Within a period of 20 years, we expect the proportion from 28% to 73%. So that is a huge jump in 2 decades. And the CDC, as rightly highlighted earlier, also shows that nearly 50% of the people with HIV in the US are 50 or older, and the European countries also predict that 50 or older will account for nearly 70% of the people with HIV by 2020. So now we are actually counseling our patients for more holistic care rather than just viral suppression, which we are achieving. It is the long term effects of the drugs, the disease, the comorbid illnesses which are of concern. As we see, 50% of the older adults are diagnosed late in the course of disease, which is quite common in the Indian context. I'll be discussing that a little bit later. There is an increasing effectiveness and lower toxicity of ART, we all know, which has decreased the AIDS associated conditions significantly. And whereas the prevalence of chronic end organ diseases has increased, and if you see worldwide, more than two-thirds of deaths among people with HIV are now attributed to non-HIV associated diseases. So that is something which is a sea change in the 21st century, I would say, which is happening. This was a survey conducted in the US very recently, the HIV National Survey in 2020, where they said that 48% were older than 50 years of age, and coordination of care was vital due to intersection of HIV and aging. Going on to comorbidities, well, there are a whole lot of comorbidities. We all know, especially the Indian subcontinent, we are more prone to the cardiovascular, the diabetes, the liver disease, COPD because of increasing air pollution. And apart from that, non-AIDS cancers, osteoporosis, frailty is another new concept which is actually catching up, and we are doing currently a study of frailty in patients who are virally suppressed. They have found that patients who are, although virally suppressed, tend to be more frail than their counterparts. Cognitive dysfunction, depression, these are some of the things which are very, very common seen in these patients, no matter how much social awareness programs, how many things we do, but there is still a lot of stigma attached with the disease. People do not want to share their status. They do not want to discuss it. They do not want to disclose. They have inherently depression, whether it is the younger age or the elderly, they would have a lot of issues regarding that. And as Indians, we are a decade earlier than our Western counterparts for a lot of these comorbid illnesses. So we have to have our guard up when we are treating or managing such patients. So this is just a repetition of that slide only. That was a diagrammatic representation that cardiovascular, cancers, osteoporosis and osteopenia, bone fractures, which are attributable to age and other comorbid illnesses, but also to certain drugs like TDF, which are gradually phasing out. But yes, there are still a lot of patients who are on TDF, LV dysfunction, liver failure, kidney failure, cognitive decline. So all this is something which is there, and a whole lot of work is going on this, and it is a chronic inflammation during the treatment. There are the multiple factors which lead to inflammatory process and causing this monocyte activation, T cell activation, endothelial dysfunctions, dyslipidemia, hypercoagulation by the virus per se, or because of the ART drugs, co-infections like CMV or microbial translocations. So there are various factors which lead to this chronic inflammation and leading to these comorbid illness acceleration, which we just saw. The other traditional risk factors are always there, like smoking, hypertension, diabetes, obesity, which would anyway be there and accelerate and cause more morbidity and mortality. And if you see, AIDS is different, as Dr. Gilada said, that things were different. It's no longer the Kaposi's and the PCPs, but it's more of diabetes, heart disease, high blood pressure, and cancers, and the disease has actually evolved. But this is again going back to the survey from which shows that more than 50% would have at least one comorbidity. Either it is depression or a dyslipidemia or hypertension or neuropathy. And it is these complications which, due to chronic inflammation, there may be joint pains or back pains. So again, this continuation of this, it shows that 56% may have depression, 31% have a mental health issue other than depression. More than a fourth would have a traumatic stress disorders. 46% felt down or depressed. 39% felt lonely, and 25% went 24 hours without interacting with other people. Whereas if you compare it, this is the people aging with HIV rather than without HIV. So this is again, these are figures which are quite alarming and which needs to be addressed. So key points from this survey and the slide so far is that non-infectious complications of HIV remain an important source of morbidity and mortality with the aging population. These problems will persist despite the widespread use of early ART, and very large population of people treated with low CD4 and other, and many who remain untreated globally. These factors would be there, and interventions to reduce long-term complications are still needed. We need to follow this up patients and see, because as we are seeing, long-term data would be required, how they behave, and we need to assess and modify the traditional risk factors for cardiovascular disease, CNS cancers, and other liver disorders need to be addressed. So just a very typical kind of a case scenario. This is a patient who was diagnosed way back, comes to you with he's a diabetic, COPD, CKD, osteoarthritis, history of alcohol, tobacco use, is although adherent to ART, is currently virologically suppressed. So you would see a lot of these kind of patients who are living long, but they have now developed over the past 5-10 years comorbid illnesses like diabetes, CKD, COPD, osteoarthritis as part of aging, and they were found to have severe hip pain, found to have an orthopedic surgery evaluation is done, and the patient is advised a hip replacement. But a lot of things come into play in these kind of patients. Whenever they are going to a smaller hospital, there is that mindset, either they would be refused treatment once they disclose their status. Then there are issues related to drug usage, because they are taking drugs like TDF, which is affecting. So how would you monitor or manage these patients? The response from the surgical team, all this, plays into the mind of such patients. And probably this was the reason, probably this patient who was at a secondary care center initially did not get a treatment because of this kind of a apprehension. So these are the kind of concerns which are there. There is, you have to have intersectionality, you have to have interconnected nature. So despite the race, class, gender, there are more and more people coming up with their sexual orientation, with the openness in the law. So we have to accept them and make them understand gender identity, race. There are a lot of these issues which have to be considered apart from aging, and this so as to be considered, so as a better management is concerned. Because if we are not able to cater to these issues, as I showed, the issues of depression, social isolation, loneliness, lower status disclosure, the patients will not take maybe not may not be compliant with the treatment, or may not disclose their status, so which may lead to adverse clinical outcomes. So it is very important that the stigma is done away with, because as we see, despite all this, the aging people are more likely to have these kind of problems than the younger counterparts who are positive. So going to a very recent case, we just happen to manage this patient. This gentleman comes to us. He's a 70-year-old gentleman who is quite educated. He comes up and he comes for evaluation for a significant weight loss and severe weakness. He has around 8 to 10 kilograms of weight loss. He has severe weakness. He has a basic workup done. He's hypertensive, diabetic, and he's found to be HIV positive. So what are the issues, generally you would fail? Now this is a 70-year-old gentleman. He has a 65-year-old wife. He has a 40-year-old son. And he has issues like how to disclose it to the son that, that he is positive. So that is a very big scenario as to how to disclose it to the family, and how do they come to terms as to, what happened and how he contracted it. So there are a lot of social issues which come up, apart from things like he's already have comorbid illnesses like hypertension, diabetes. So you have to cater the treatment accordingly. So these are certain things which are there. So that is why you have to have these optimal health management, where older adults living with HIV require comprehensive co-located care programs, where you may need the help of geriatric medicine, mental health, ID person, cardiovascular, internal medicine, oral health, nutritionist, visual issues, hearing issues, which may be there. So it has to be an integrated approach rather than just giving simple ART, because that is what they would probably need for better care. So these are the 5 M's which the geriatric population would require: the mind, mobility, medication, multi-complexity, and the matters most. So it is the mentation, the dementia, the delirium, depression, and there would be impaired gait and balance, fall and injury prevention, because these are the issues which are there. The other issue is polypharmacy, because a lot of them would be having on other drugs which may have drug interactions. So we have to be very careful, take a detailed history as to what drugs they are on when we are prescribing ART drugs, because ART drugs, especially PIs and all these, they have a lot of drug interactions. They may be on cardiac medications or anticoagulants. So there are issues which need to be seen, because all of us cannot be knowing all interactions. So probably apps like Liverpool app may help us, and we try to give as minimal and optimal drugs. Medication burden, adverse medication effects may be there. So multi-complexity, there is multi-morbidity, and complex biosocial situations are there. And if you see, what matters most is that each individual's personal health outcome, aims, and care preferences. So you have to, you know, it is more like a cafeteria approach where you discuss with the patients, assess their needs, and manage them according to their needs and aspirations as to they want treatment, they want a single pill, what other management they need to be. Those are going on to prevention and care challenges. So the issue is, another issue which is there is a lot of older adults, may not practice safe sex, because when you're older, you feel the initial safety sexual practices may be there to prevent pregnancy. So once you're old, your partner is old, you are less worried about that. So you may not be using that kind of safe sex practices. So that may, lead to transmission. So that needs to be there. Then impact of ageism, discrimination, stigma, which needs to be managed, because as you grow older, as showed you in that particular case, that a lot of issues, family and social issues comes up, which needs to be catered. And as healthcare professionals, if we see a younger adult with acute symptoms or these kind of symptoms, we are much more vigilant and alert in getting an HIV done, rather than for a 60 or a 70-year-old gentleman. So that is also a condition, something which we all should be aware, that it is not a taboo to have in this kind age, as they may be harboring it for long, or they may acquire it later. They may be elite controllers. So what you have to do is better medication adherence is what needs to be there. As there will be increased number of comorbidities, there will be higher risk of polypharmacy and drug-drug interaction, as I said, and higher risk of social isolation. Another issue is alcohol use, aging, and HIV. As we see, low risk drinking. So, well, I'm not going into the details. Most of us are aware what is low risk drinking if you're not drinking too much. And what actually is that alcohol increases the brain's sensitivity is increased to alcohol as the levels of alcohol go as per the dose as compared to the younger people. So if somebody is 20 and is drinking 4 drinks, and somebody is 60 having 4 drinks, then he should be a little more cautious, as the brain hypersensitivity is there. And alcohol, even at low risk levels, may adversely affect a variety of medical and psychiatric conditions and impact negatively with a variety of medications. So that's why it is very important, because by the time you are 70, 60, you may be on a whole lot of medication. So there may be drug interaction, hypersensitivity because of this. So need to be careful. And it has been seen that alcohol use is associated with non-adherence of medication. It decreases the overall survival and lifetime prevalence of alcohol use disorder 2 to 3 times higher than the general population. I know a lot of my colleagues will be unhappy with me showing this kind of slide, but then yes, if you are taking too much of alcohol, it is harmful. So to sum up, as the HIV population ages and the rate of newly detected infections in the elderly rise, clinicians should be aware of the increasing need to balance HIV care and the management of comorbid conditions commonly associated with aging. And the older people are prone to the risk for developing health complications associated with chronic viral infections, deficiency of vitamin D, and development of bone diseases, exposure to such medication with severe side effects and toxicities, and reduced levels of immunity. Age related immune senescence, which is usually augmented by HIV infection, may add to the growing challenges for controlling viral loads and optimizing CD4 T lymphocyte counts. Therefore, keeping such immunological events in view, the management strategies need to be adequately developed and modified to get expected results. So, with this, I would like to hand over to Dr. Gilada and the panel to take it further. Thank you so much.
Thank you, Atul, for this wonderful talk. It really has made us wiser. I remember some of the people, we used to educate them that alcohol, HIV virus is very fragile. It dies with alcohol. And they used to say that by drinking alcohol, virus will die inside. But it is not so. And
It will happen in the bottle.
Yeah, yeah. And I remember of traveling with a minister once in a train, and he was around 50. So he said that if with HIV life is around 15, 20, so why should I protect now? Because anyway, if I get HIV now, it will be another 50, 20 years to survive, and that much is a normal life. So I think all those questions, what you said, that older people, they don't want to use protection. People are diagnosed for the first time when they are 65, 70. So they may be infected earlier or they may be infected at that time. And there are issues with the mismatch between couples where they were very much monogamous couple for maybe 25, 30, 40 years. And suddenly wife becomes a little bit more religious. And I've seen in one of the Jain communities where some female, they take Diksha. Diksha means they have to consider their husband like their brother. So they don't allow husband to touch. But husband has not made her sister. So he will go out. So I think all those issues are there. And we have individually come across several such issues. I think when we open up for discussion, a lot more questions will come from the audience also who are attending the talk. And I will encourage also Manoj to share his experiences because he has been living with the virus and he is in the part of the community nationally and internationally. So he will have his own experience. So at this stage, I would like to involve my co-panelist, Dr. Milind Bhrushundi is a major. I don't consider him minor, though he is minor to me in age. He is major. Dr. Milind Bhrushundi is ex-medical specialist, Indian Army, awarded with Siachen Glacier Medal, Arthur Ashe Fellowship, Department of Infectious Diseases, Well Cornell Medical School, New York, USA, and Certificate of HIV Medicine, Department of Infectious Diseases at UCSF. Invited TRG member, National AIDS Control Program, NACO. Official Goodwill Ambassador, IVLP in HIV/AIDS, invited by US Department of State, USA. I take pride here to introduce him there to the State US Department, and he was the only representative from India to go there. Presented 10 papers in ISC and 4 papers at IS conferences, 1 original paper in Science, and included 2 meta-analysis in Lancet Infectious Diseases. Ex-professor, ex-associate professor, and lecturer in Jawaharlal. I don't know whether he's ex-lecturer or current lecturer. Ex is not put there. At Jawaharlal Nehru Medical College, Savangi, Government Medical College, Yavatmal, and Nagpur. Professor at DMIMS Institute of Medical Sciences in, I think, Datta Meghe Institute of Medical Sciences, Nagpur. Associated with Sarthi, which is a CBO, and Sanjeevan, which is PL HIV organization in Nagpur. AIDS Society of India, ex-Secretary General and Governance Council member of ASI. Next panelist, please. We have my colleague, Dr. Prakash Bora. He was my senior in JJ Hospital when I started my career in JJ Hospital. He's honorary consultant in HIV and AIDS at Grand Medical College. GMH is what? Grand Medical College in hospital. Affiliations, Godrej Memorial Hospital.
past honorary associate professor, University of Seychelles, USA, Department of Infectious Disease and AIDS and STD Research Center, MGM Medical College and Hospital, faculty at Hukart, and he's also the governing council member of ASI, now retiring. Next panelist, please. We have Neha Gupta, who is a young ID specialist. She is MD in internal medicine and FNV in ID, first batch of FNV ID in India. ID observership at CMC Vellore and Wayne State in USA. Ex-consultant in and ID at Hinduja Hospital in Medanta, the Medicity. In 2016, she was a healthcare award. She received a healthcare award from Director General of Health Services, Government of India. Executive member of CIDS since 2012. Senior ID physician of Fortis and founder NG Swast Infectious Diseases Clinic at Gurugram. Next, please. Mr. Manoj Pardeshi, being in company of doctors, many times he is also called doctor. Specialization is worked on various aspects of HIV response, including conceptualizing, designing, program management, and financial oversight. Designation, project manager at TAL, which is one of the wonderful projects in India and is replicated in many places, plus integrated health center, IHC, and community pharmacy, CP, General Secretary of NCPI, which is a national organization of people with HIV, and NMP Plus, which is Maharashtra organization. Current affiliation, he is founding member of the country's first peer-led TAL, plus Link ART Center for public and TAL plus IHC and CP. He has some of the major awards are basically member of NACO's Treatment Technical Resource Group and Ethics Committee, member of Community Scientist Subcommittee and Global Community Advisory Board and AIDS Clinical Trial Group, ACTG, member of Ethics Committee of Biomedical Research of ICMR. And I have known him for more than 2 decades, from the most docile and very active community members from HIV positive community in India. I think all these panelists are introduced. Let us have the panel discussion. I have already some questions. Okay. Dr. P. Narendra Singh is attending from Manipur, Imphal. His question is, how frequently do we see long-term survivors? I think he means to say that how frequently we should be examining them or investigating them when they are long-term survivors. Atul, you would like to take that?
Yeah, sir. So I think long-term survivors, all of us are now seeing a whole lot of patients who are surviving long. They are living near normal life, as you said. And it is the comorbid illnesses which need more management now, because somebody who is 60 or 60 plus, they would definitely have comorbid illnesses, and that needs to be monitored. So if a patient has diabetes, hypertension, so I would suggest a 3-monthly follow-up for these kind of patients, barring depending on what kind of comorbid illness or acute illness it is there, but at least a 3-month follow-up would be required.
Next question goes to Dr. Milind Bhrushundi. This is from Dr. Bharat J. Arora. Why do patients with normal CD4 count and viral load under limit suffer from multi-drug resistant tuberculosis? Milind?
I'm not getting the question.
The question is, why do patients with a good CD4 and virally suppressed, they suffer from multi-drug resistant tuberculosis?
See, if you talk of CD4 and undetectable viral load, and then if you are trying to correlate with multi-drug resistance, I think we have to see also that multi-drug resistance do exist in non-HIV patients also. So it is not that the CD4 is the high CD4 or low viral load is going to be a negative factor in not causing the MDR. On the other hand, also we do have process what has already been told, that whether this is totally non-detectable or there is a low viral viremia. So these two things have to be differentiated. It is not just like that a CD4 is very high that doesn't mean that he is not, he can have this infection as a general person also.
Okay, next question goes to Dr. Prakash Bora. What is the life of a HIV positive couple? Is couple setting where both the members of the couple, they are positive. What is the life? Can you unmute, Prakash?
Can you hear?
Yes.
How the couples are leading a normal life and they have almost a normal lifespan when they are on ART.
Okay, next question is there any permanent treatment for HIV? Neha?
So as of now, we don't have any cure for HIV, but we have very effective medications which can completely suppress the viral load, and people can live their normal life like any other person who does not have HIV infection.
Any other questions from audience? If not, then we'll start from our own discussion.
Dr. Gilada, can I come in here?
Coming? They're not coming to me. Where are they coming? In chat
Okay.
board?
Should I start the discussion among us?
Start.
The first and foremost thing which I would like to convey here is that has come from one of my patients. And he is now coming to me since 1998 and now he's 89 years of age. And what he has said is really fantastic. He says that मैं लड़ाई लड़के आ रहा हूं जो हारने वाला था, मैं लड़ाई लड़के हारने वाला था, मैं लड़ाई लड़के आ रहा हूं जो हारने वाला था, लेकिन अभी भी मैं लड़ाई से लड़. So that is what exactly we have to see. And this fellow is from, like, if you are talking of LTS, that is the long-term survivors, we are having basically the pre-heart and post-heart LTS. So this pre-heart, these people who have seen their near and ones dying, so these are the main people who are going to develop what we can call as AIDS survivor syndrome, where the depression as well as other things will be much more. As well as we are not looking at one another thing, another type of LTS, apart from the post-heart era LTS, those are non-HIV, but they are supporting their family members who are positive. Just imagine about their plight also. The doctors who are treating them, the PLHIV, just imagine, sir, how you place yourself when a particular person is taking medicine religiously for more than 20-25 years, coming to you every 3 months. I myself cannot imagine going to a doctor every 3 months and doing tests. So really it is commendable. I want to hear Manoj should come up here and Manoj should tell to the audience that what exactly the feelings of a village are there who are the LTS.
No, but Milind, those days were very different when the toxicity of medicine was there. Currently, we tell what 5 years back we used to say that HIV is like hypertension and diabetes. Currently, what I say, people, if God comes to you with diabetes in one hand, HIV in another hand, which disease will take? You need to take one. And a lot of people will prefer HIV. So if we convince the people in this way, for 30-40 years, people are taking hypertension medicine, diabetes medicine. Those who are juvenile diabetic, they are taking whole life diabetic medicine. So I don't think that is the issue. Issue here is all of us as early beginners, we were in burnout syndrome that time. And that burnout, I realize now that was associated with our people dying, patients dying. Now, because of the excellent medicine, that burnout is not there. Now, we don't know how long we survive, but we know that another 10-15 years, if we survive, we are going to serve the community. So that burnout, which was there, Dr. Bora will agree with me, and probably you may have also gone to burnout.
Absolutely helpless during that time.
Yeah, they're very difficult. Yes, Manoj.
No medicine, and the amount of expenses were tremendous. And
Yeah.
it was all
And now NACO has come in picture from 2005. But at that time, if they had 3 members in a family, and they will say that sir मेरे पास एक का पैसा है, किसको ट्रीट करना बताओ, मैं बच्चे को रोते मरते हुए देख नहीं सकता हूँ, बीबी को मैंने HIV लगाया है, बीबी बोलती है कि ये मर जाएंगे तो हमारा घर कौन संभालेगा. And it was such a difficult situation at that time. The things have become much different now. Manoj.
थैंक यू सर. एंड मैं आप सभी मतलब आप सब डॉक्टर हो लेकिन हमेशा हम एज अ फ्रेंड रहे, तो आई थिंक दैट इज वन ऑफ द रीजन फॉर लॉन्ग टर्म सर्वाइवल. एंड सीरियसली द कंट्रीब्यूशन, मतलब इतना डिफिकल्ट मतलब फियरफुल डिसीज को यू ऑल पीपल मेड इट वेरी सिंपल एंड ब्रॉट इट अस, मतलब एक मोटिवेशन आप सबने दिया है. तो फर्स्ट ऑफ ऑल थैंक यू फॉर दैट. Also, thank you for Hetero being like introducing all new medicines, bringing all new medicines in India. And Hetero is also like Mr. Nehru is always there to support in all stopout situations. So, sir, दो तीन बातें मैं बोलना चाहता हूँ. जो डॉक्टर अतुल सर ने काफी इश्यूज बताए. एक सर जो बॉर्न HIV लोग हैं, जो एक तो एजिंग के साथ मतलब जो एज के साथ HIV के साथ जी रहे, और जो बॉर्न HIV मेडिसिन सालों से खा रहे, जैसा आपने एग्जांपल दिया कि 28 साल तक तो उसको पता भी नहीं था. देन सो दैट केस इज माइट बी parent to child transmission, right?
Yes, yes.
Right. So there are children those who are taking ARV from 25 years, 30 years. So those also are falling in this group. That is one thing we should consider whenever we talk about HIV and aging. So this aging with HIV treatment, that's one group we can consider. Sir, mainly the journey of HIV and journey of ART is जो aging का है वो faster कर देती है. Even 40-year person is looking like a 50-60-year-old. You must have all noticed that. And again, it's causing lots of mental health issues and plus other issues. Government, we thank government कि उन्होंने टेस्ट एंड ट्रीट इंट्रोड्यूस किया, वायरल लोड इंट्रोड्यूस किया, काफी चीजें की, न्यू मेडिसिन लेकर आए. लेकिन एट द ग्राउंड द ART सेंटर इज जस्ट अ ड्रग डिस्पेंसिंग सेंटर. सो द क्वालिटी ऑफ ट्रीटमेंट एंड मतलब सरकार सोचती है कि सर्वाइवल बढ़ा दिया, बट सर्वाइवल इज डिफरेंट एंड क्वालिटी ऑफ लाइफ इज डिफरेंट. सो ऑल द इश्यूज विच वी आर टॉकिंग करंटली इज जैसे अतुल सर ने बोला कि बाय 2030 70% पीपल विल बी HIV and aging in the country. So 70% is a big number, and program approach is still just dispensing drug. No suspects of early जैसे NCD है या CVD है या ऑस्टियोपोरोसिस है, ये तो सब कोई सस्पेक्ट करने का, उसको टेस्ट करके आगे जाने का तो कोई मैकेनिज्म ही नहीं है. स्टॉक आउट इज ऑल्सो अनदर मेजर इशू. कोई भी अभी एवरी डे न्यू सर्कुलर इज कमिंग, दे आर चेंजिंग. अगर ये ड्रग नहीं है तो इसको रिप्लेस कर दो, ये ड्रग नहीं है तो इसको यूज कर दो. दैट रैम्पेंटली मिसयूज ऑफ रेजिम्स is also another big concern for future. So that's something which we can take it together with TRG. With HIV हमने pill burden तो कम कर दिया, लेकिन other pill burden has increased. I have to take calcium, I have to take hypertension, I have to take statin therapy. So बाकी कम से कम 5-6 pill बन गए और ये pill छोटी छोटी होती गई है. So that is one thing which we need to think. सर, एक जो पेशेंट लिटरेसी है, इवन लाइक जैसे डॉक्टर गिलाडा ने कहा और सर है यहाँ पर डॉक्टर गंगा थे कि शुरू में जब ARV नहीं थी, मतलब इन आवर थिंग, हमको सिर्फ इतना था कि अच्छा खाना खाओ, अच्छा पानी पियो, CD4 को मेंटेन रखो. तो दैट टाइम आई थिंक पेशेंट लिटरेसी वाज वेरी हाई, very high. Suddenly, I might be devil's advocate, test and treat has killed the purpose. People are leaving medicine within first 3 months after initiating on treatment. Maybe in private, because of good quality of counseling, people might be आपके साथ ज़्यादा वो रहेंगे treatment में. But in government program, we have to chase people every after 3 months of follow-up to follow-up. One message which I like considering, we also discuss on that, is that a regular checkup is something which we need to do regular, like at least there's a 3 months interval. We meet our doctors, share our issues. Doctor also need to ask some questions where suspect the other complications of this, which that is not there, and how we can build that. Maybe I like all expert panel, you can suggest what advocacy we should do with government to bring that approach into the program. And lastly, the role of peers is slowly going down. And that like reviving that role and importance of that role is something we need to bring back to the program again. Thank you, sir.
Thank you very much, Manoj. You picked up rightly from the ART setups. And if you remember, for last at least 10 years plus, AIDS Society of India is making effort to bring ART officers to the conference or training programs. We bear their expenses. We sometimes bring them at our cost. Despite that, we do not get that much of support from the national body. Till today, AIDS Society of India has not got 1 rupee from NACO, 1 rupee. And we stopped asking for last 10 years because there's no point in sending application and follow. So we'd like to appeal the community of PLHIV that thrive upon NACO. I can assure on behalf of Milind and Prakash and even Atul, Neha, that we'll provide our free services to ART centers. We'll provide a kind of training programs to them. Let them come forward. But it has to be, we are not asking anything in return. No recognition, no certificate, no award, nothing, no money. But if that kind of services we are willing to provide, we should not be seen with suspect. What happens when we send our patient to ART centers? The ART officer will first say, "Acha, आपका पैसा खत्म हो गया, इसलिए डॉक्टर बोरा ने आपको इधर भेज दिया." This is a nonsense thing. You are not working free of charge. Okay, you are paid little. You fight for it. ART officers are paid only 45,000 or 50,000 ad hoc salary. So I think we should fight for their dignity, their decent salary. But at the same time, public or private, all are working for the welfare of patients. They are working for n number of people. We are working n tenth of people, but we are working. So this basically that attitude has to change, and this has to be done together with PLHIV community, the NACO or State AIDS Control Society, and AIDS Society of India, or any such organization like the Infectious Disease Society is there. So unless until we come together, this will be, as you said, the pill distribution organization or a pharmaceutical organization that they are just giving monthly tablets. And that's the reason we fought and we said that it should be multi-month dispensing rather than 1 month. So at least they started with 3 months. One wonderful thing they have done, and I always salute NACO, is during the lockdown, before lockdown started, they started mobilizing. And they made a circular to all over the ART centers that if a patient comes from even private practitioner from anywhere, provide them months of medicine till lockdown is there. So our patients which were stuck in remote places, they all got medicine. Okay, they may not have got the medicine which they were on, but at least something was better than nothing. So they have done that, and really some of the current officers in NACO, they are very much proactive and they work day and night for that. But I think whole as an organization, they need to stand up. They need to fight, and that is not happening. And that is you and we have to fight together along with the national agency. This is one question which has come from Dr. Bharat Arora. Can a patient's partner be positive after 10 years? Or in other words, can window period be 10 years? Anyone can take it. Yeah.
So to my knowledge, basically the currently available HIV diagnostic tests, the P24 antigen, the window period has been definitely shortened to just 15 days. So we have earlier, we have the generations of ELISA. We have the HIV first, second, third, and fourth generation. Now, fourth generation is the one which is followed, and it has a window period of only 15 days. The earlier generation, first, second, they had a window period of close to 2 months. So that's why it was longer. But 10 years is a long.
You would like to know, yeah, window period can be of two types. One is the fighting test positivity, and one is to get symptom. Ideally, window period is called the origin of first symptom or availability of first symptom from the disease acquisition. That could be as high as 5 years, 10 years also. Any other questions? Vijay?
Unless up till now, these were the questions. Otherwise, we can take the other discussions which we had.
Panelist, any of you want to make any point of order or any point of what we discussed?
Just wanted to say that, I mean, there was a comment from a positive person. So what he says is that hug changes body chemistry. And that's what Manoj is saying, that there should be a human approach during the management of the positive patients. And I think that is something which we are lacking somewhere. And second is the insurance part of it. Still, even if the act is still there, still the insurance companies have not come up with the right proposals. And I think people are not able to take advantage of that. And I think we need to have that policy to see that they get Mediclaim, not only life insurance.
So
Another important,
what Dr. Bora is suggesting, that currently Mediclaim policies, though the illness may not be HIV related, but they don't give claim. They don't pass claim. And out of 10, 8 people or 9 people do not fight. So 9 people lose the claim. It may be knee replacement, it may be heart surgery, it may be anything. Secondly, even for LIC, they have a policy. If the policy is more than 10 lakh, then HIV test is compulsory. So they may not say that because your HIV positive policy is not given, but the policy is declined. And such cases have come. And lastly, this HIV/AIDS Act 2017, which is a toothless act. Manoj will remember that I was there in a program with the NACO, and I told and NACO people didn't like. I said, show me what are the tooth. Where are the teeth? How many people are prosecuted in the last 5 years? None. Not a single case. So day in and day out, people with HIV are discriminated. And lastly, I'm reminded of my early days in JJ Hospital. I was in charge of leprosy ward. And before I was examining that patient was seen by some doctor. And the patient was very much sad mood. I asked him, Baba, kya hua? And he said, sir, किस्मत की बदनसीबी है, सयाद क्या करेगा? किस्मत की बदनसीबी है, सयाद क्या करेगा? हकीम है बेदर, तो फरियाद क्या करेगा? So if doctors don't have passion and compassion, where the patient can go? So doctors who are working in this field of HIV or leprosy or tuberculosis, where there is a stigma attached, stigma of contagion, stigma of sexuality, stigma of minority, whatever. There we have to be extra cautious, and we have to put a pat on the back, give a hug to patient. They will not feel that they are unwanted, and that much walking that extra mile is required by doctors in the field of HIV. Yes, Neha, you were saying something.
yes. So I was saying that as more and more people are living longer, it's very important to prevent. Regular monitoring is definitely needed, and we have effective vaccination strategies which can be also offered to the patients for prevention of infections.
Dr. Gilada?
Yeah, boliye.
Yeah, I would like to take on the things which you have said, that if God comes on earth and asks me to take either HIV or diabetes, I will go for diabetes. I will go for HIV and not diabetes. But sir, here, when I tell this particular thing to my patients, first thing which they say is, there's no stigma which is attached to diabetes. So what I feel that for long-term survivors, even they are not able to take now because their son, daughters, they have grown up now, they have to have a support from the family and the society. Though whatever we say, that a stigma has decreased, but no, I will definitely 50% like to disagree with that. Stigma still exists. Stigma exists in families, in society, with doctors and everybody. So what I think is our role in decreasing the stigma and discrimination. That is very, very important. Another point which Dr. Bora said was about the insurance. Why we are not fighting for the insurance for the PLHI? Initially, I remember one Star Insurance, they have started one, but ultimately they also stopped. We had a good association with the Star Insurance with TAL, and they also stopped. But we have to, IRDA has to be told now strictly that we have to have the more premium, but at least we should have the coverage for all the PLHIV. That should be our first agenda. And you will not believe it, but I have already shared with you, for doctors also who are treating HIV, you are not going to get indemnity insurance even if you say that you are treating HIV patients. So they decline your indemnity insurance. So insurance is a part which has to be taken very seriously, not only by Manoj, but by all of us. Manoj is we all know Manoj, that he's trying his level best. We have seen him for the last 2 decades now, how he has fought for each and everything. But now it has time has come that seriously, at least because you said a long-term survivor having a knee replacement, because he is HIV, his insurance is denied. So we have to do something for this very, very seriously and totally with devotion. Whether it is NACO or whether it is a ASI or whether any PLHIV, we have to come together and fight it out with IRD.
Thank you, Milind, for this update. I would like to also tell that many of the times this stigma is self-inflicted stigma. Many of the times, I'm not saying 100%. Any person who is diagnosed, actually our stigma prevention, discrimination prevention should start from the first disclosure. That after this you would like to disclose to someone, too close to your family, or you want to keep it to yourself and think of pros and cons. A lot of times patient coming to you, or before coming to you, or after coming to you, they go and cry with somebody, maybe a friend or maybe a sister or brother, and from there the matter spread, "Arey, mere bhai ko kaisa ho gaya yaar?" And then the matter goes to community. There are people who are HIV positive for 25, 27, 28 years. None of their family members know till today.
Yeah.
There are people who are registered with us as an anonymous or with the assumed name, until they are going to have death certificate to be written in real name. We maintain that kind of confidentiality. They are not facing problems. So I think we need to prevent stigmatization and this kind of discrimination very much when they are diagnosed. And my idea of saying about HIV and diabetes is not in open. If when a patient comes to you when diagnosed for the first time with HIV with the sad faces, that's the time we say this is better than diabetes. At least in diabetes, there are a lot of problems. In HIV, we don't see that many problems. Problem can be there with HIV and diabetes, but at least HIV per se doesn't cause that problem. So that was the context of saying. As far as insurance is concerned, ASI fought, ASI wrote to IRDA, IRDA prevailed upon all the agencies which are giving insurance, except Max Bupa. Nobody accepted. Max Bupa accept that. Max Bupa is not going Neo Bupa. Star, their premiums are very high. I think we need to have some kind of cases going in court. In this country, government, executives, officers, organizations don't work. I don't say in that sense that they don't work, but nobody listens to them. So when there is a law, then the only agency which can make that law being implemented is court. Go to court. I don't mind partnering with the PLHIV community, going in Supreme Court, going in High Court, different places. That where are we in vis-a-vis HIV/AIDS Act 2017? If today patient goes to any surgeon charges double fee because you are HIV positive, you will be taken last in the theater. We started saying that the person could not give HIV to his wife, sleeping daily with wife. How can you get HIV from him? So we started writing undetectable, is a target not detected, zero virus, all sort of thing. There are surgeons, neurosurgeons, cardiac surgeons, orthopedic surgeons. They are providing services. But many of the places, they charge extra, hospital charge extra. They ask the patient to be single in the double occupancy room and pay for the entire room. All these kind of ifs and buts are there. But I think we need to fight. Sometimes it is fighting against our own community, but we need to fight.
Sir,
Yeah.
I remember we had made a poster that time in 1990, and it was saying that there are ways to stay healthier, strengthen immune systems, and develop possible attitudes. Change of lifestyle, proper nutrition, and early medical intervention can put time on your side. And I think that is same thing which is now for the comorbidities. The same thing will apply. And I think we need to inculcate yoga, pranayam, nutrition also, in the preventive strategies for this aging process. How to
Another
make aging healthier is the challenge for all of us.
Another thing, Manoj, for your community, one good message is that I always tell my patients when they come with their relatives who are HIV negative, I tell them, health of my patient is better than your health. And we have proved that many times. The relatives have died in COVID, our patient did not die. The relatives have died of heart attack. I said, you maintain air condition, you maintain car, but you don't maintain your body. But the moment I tell you that when was your last checkup, अरे गिलाडा साहब आपको तो दुकानदारी चलानी है, आप क्यों टेस्ट करने बोल रहे हो, मेरे को तो कुछ हुआ ही नहीं है. So I just give them example. So healthy people, those which are HIV negative, they don't go for any checkup. At least HIV positive people, we see their all parts, spare parts of the body, they are maintained very healthily. So I think when sometimes we see HIV positive person surviving, HIV positive person's wife died, who is negative, brother dying, who are negative. So that, and these are the messages to be given to the community, that actually we tell them for smoking, tobacco, alcohol, everything. We don't say to any other community, but we tell HIV positive people, and a lot of them, they listen to advice, they stop their smoking, they stop. We tell them that you save some money out of this, it may be useful when suppose some medicine is not available, which is expensive, you are needing that money can be saved. The people are there. And one more thing, for stigma reduction, we did one program, we did a couple of programs. That program was called Ye Jeevan Hai. Ye Jeevan Hai program was for doctors, HIV positive people, pharma companies, friends and family members. And in that whole hall of 1,500 people, no one can spot who is HIV positive, who is a doctor, who is the family of a doctor, who is a pharma company man, who is a representative from media. And it is like ye jeevan hai, is jeevan ka yahi hai rang roop. Thode kaate, thode khushiyan. And that, and patients were in tears. They never thought that they can be brought to, like thereafter they would like to come and say that, yes, I have HIV. So what? People then accept. So when you do that kind of experiment, I don't say experiment, but you should do such kind of program where people are more open, they come. Another thing I would like to tell you, for my elder daughter's wedding, Trupti's wedding, I had invited 100 patients with their wives in my wedding, in the wedding program. And I have never disclosed that they are HIV positive people. And I was myself was in tears to see people coming in suit boot, Hawaldar or somebody, they were dressing appropriately for the occasion. And that is a way of, you can reduce stigma. You give them, you see, ultimately, if I spend somewhere to my reception, I earn from patient only. So when it goes back to patient, nothing happens. But at least that message goes that here everybody is equal. I think that if we make effort individually, in my clinic, one person who works with me is HIV positive for last 20 years. Another person who works with me is a Devdasi turned sex worker, and she's working with me for 30 years. And lastly, I would like to tell that when you talk about long-term survivors, we are only talking about long-term who are on ART. I have at least 50 plus patients which are without ART for 20-25 years. They are surviving. So they are long-term survivors, elite controllers, viremic controllers. We don't give them just test and treat. It doesn't mean that you treat everybody. So we need to make that kind of differentiation also. Yes. Yeah, Manoj.
So 2-3 things actually. Basically, like this, there is a target for everyone. So ICTC has to test certain population. After testing, they have to send 100% to ART center. Once I go to ART center, then ART center has to immediately put me on treatment. So in this process, the quality of counseling is lost. My target is to just to send this person to ART center. Then ART center target is to just as early as put me on the treatment. And that is causing a huge issues, like because there is a no treatment literacy approach. Secondly, there is hardly any message on life after infection. So the generation where we saw the treatment is not in our purview. For us, like healthy lifestyle is the first message. And that is why like you were saying, the people still surviving with 25. I know there are some factors of which is making them without like more long-term survival, but still those messages are gone. So we need to bring back those messages again. On what Dr. Bhrushundi is saying, yes, it is right. Stigma is not gone yet. There are two, like self-stigma is still there, but self-stigma is the also outcome of the outside stigma.
Yeah.
So it's a chicken and egg situation. So it's still not gone, still it is there. On part of insurance, I like your idea. Let's jointly we can put up PIL in the code and let's take it further, because it's going from one pillar to other pillar. It's not solving the purpose, and we can go jointly on that. So again, one point here I want from all of your side is that you are looking as a treatment provider perspective. I like how we can empower like the patient perspective. Like if I am taking, how can I take charge of my life, my body? That approach, how we can bring, and in this, if you can give some tips, I will be more happy to take it with the community.
Excellent suggestion. Atul?
Yes,
Any?
sir. So I think there was very interesting discussion going on, and as he rightly said, apart from the issues which already been discussed about insurance and all, which are very, very important, the empowerment thing, which is very important, as Dr. Gilada and Dr. Milind and Dr. Bora has already highlighted, that first of all, we have to ensure that we counsel them very well to understand that this disease is not something which is a killer disease. It's actually about spending some time, because it's only the initial, if you see what my personal experience is, the initial 2-3 visits are very important. After 6 months, 3 months, once the patient is virally suppressed, he becomes relaxed. Then, he will not call you also. He's fine. He will not message you. Initial 2-3 visits, he is very, very apprehensive. Doctor Saab, meri shadi hogi. If it's a younger one. The elder one, I have senior people who are in the late 60s or 50s who says, I have to get my daughter married. Will I live long? So there is a lot of apprehension regarding the illness, because it is a disease, because a lot of people go onto the net and see information which is full of whole lot of things. Like the question came in that window period of 10 years, this patient comes up, he has an exposure, and can I be positive after 10 years? So these are the things which keep coming into their mind. So we have to bust all these myths in the initial 2-3 visits, give them time, make them understand. It is for our community as a medical community to give. The most problem is that patients choose the busiest doctors, and the busiest doctors do not have time, and they are not able to spend time. So most important thing is at least 15-20 minutes, half an hour is required when a newly diagnosed patient is there. They need to be explained about the disease, explained that it does not matter how they acquired. There is a lot of social this thing in the family member, how he or she acquired. So that has to be allayed about the drugs, the side effects, and the thing that you are be living a normal life has to be highlighted by way of various examples which we've already discussed as to how. So these are the things which, and they have to be told about their rights, because a lot of people come up that I'm positive, I will not be employed, or my employer comes to know about my status, I'll be thrown out. So we have to tell them their rights, that this is not what is there. You can continue your job. There is no problem with that. So these are the things which need to be taken care of, I think.
Manoj basically was asking about how to take the control of their own self. Am I right, Manoj?
Yes, sir.
So see, Manoj, this was one of the really eye-opening question for, I think, all of us. The first and foremost thing which we have done at our place, you already visited many times, that what is important is the role of peer counselor. And you know that my peer counselors, they are much better than the counselors which are not, they are just employed for the sake of salary. So the first and foremost thing is all ART centers should have a peer counselor. We should start with that, because burnt out is not there with peer counselors. It is, if it is there, it is much less. That is first and foremost. And secondly, how to take control of our own body. So for that, three things are there. One is physical, that the quality of life and maintenance of hygiene and everything. That is number one. Second thing which we are trying at our place, that is a meditation. And that has really helped our patients very much. Now we are carrying out one-to-one sessions for meditation, and that has helped tremendously. So if you can have that thing like meditation session at the PLHIV groups, and that will be a really good thing, because you see, physically you might be good, but mentally, though everybody is saying that nothing is there, just tell them that you will be okay and everything, still at the back of mind, you still, that thing is there, that you are positive, and the other person, how it takes me, it is definitely at your back of mind. And if you want to go away for that, there is a good meditation we have started, that is letting go, and that is a 20-hour session, and we carried out at least once in 1 week, and those things can definitely help out. So see, non-medical interventions will help you on taking the other parts, like taking a self-control, your self-esteem, that things can be definitely brought by meditation.
So now we are at the fag end of the meeting. Anybody would like to say who has not spoken? Bora, 1 minute. Neha, 1 minute.
I usually advise my patients that bindas raho, lekin beparwa mat raho.
Bindas beparwa. Okay. Neha.
So I just tell them to be positive, whatever they have done, like whatever has happened. It's important to just accept and live life. And with all these effective medications, whatever we have, I think it's, they can lead a normal life like any other person who does not have this infection. I don't have any catchy liners like this, but yes, in simple terms.
Manoj?
नहीं सर, एक यही था जो मतलब खुद के बारे में ये कर रहा हूँ. जब भी दवाई लेता हूँ तो ये हम लोग पानी के साथ लेते हैं, तो मतलब हर घोट को मैं ये बोलता हूँ कि अभी मैंने 100 ट्रिलियन को मार दिया, 200 ट्रिलियन को मार दिया. तो इट्स नाउ बिकम अ प्रैक्टिस ऑफ
good.
So it's actually helping. I don't know, this telling oneself continuously, that is helping. And now it is also अभी कुछ थ्रोट इन्फेक्शन भी हो गया, तो फिर अगर कुछ पी रहा हो तो बोलता है अरे इतने बैक्टीरिया मार गए अभी. So I don't know whether it is working or not. There is no any this thing, but it's keeping me healthy. That's a simple one.
Atul, last words. Please unmute.
Yes, sir. So we have actually discussed most of the things rightly, as Manoj has rightly said. It is probably the positive mindset which is important, no matter what the illness is, and we have to take it in a positive way, whether it is meditation, yoga. So it is a mindset. If we have the right mindset, we will go a long way, and it has to go hand in hand, both the patient as well as the healthcare provider. That's what it is.
So at the end, I thank all the panelists, the speaker, Hetero, for having this meeting. It's a kind of very exciting meeting. The fight with stigma and discrimination is going to be a long drawn battle. Stigma associated with sexuality will not settle down for our generation, for next couple of generations. Sometimes we are with a situation where somebody is MSM and HIV positive, and both the things are not known to family, and he has to decide which of the two things are to be told first, to whom it has to be told first. So there are lots of issues, and I think all of us will have to work together. We cannot work in isolation. We cannot work on our own. And we have seen that working together will have some kind of results. We don't know if results will be 100%, but result will be there. And we need to fight out the issues related to HIV/AIDS Act 2017, insurance issues, ART centers where they should be human. There is a saying, "Ghayal ki gati ghayal jane aur na jane koe." So that there is a question of peer counseling over there. I think Manoj organizations, PLHI organizations, they have to really come out more stronger than what they are. They are really strong, but they can all good things have to change for the better. With this, I would like to hand over to the organizers, and I request them to organize such program more and more often, not only on screen but in physical sense also. Thank you.
Yeah. So thank you so much, everybody. In fact, this happens to be the 41st year where HIV long-term survivors day has been observed. In fact, this is being observed in US from quite some time. But from last 3 years, like from 2020 onwards, where basically when pandemic hit, and we were looking for more scientific and such events, and that is the time when we started off even observing in India. So since this is our 3rd year where we are observing this, and in fact, the exact date is 5th June, on which 5th June 1981 was the time when the first HIV/AIDS case was discovered, and that was commemorated as later on it's observed as HIV long-term survivors day. So what a session we had! We had an excellent panel of doctors of rich experience, the pioneers who had begun to work in HIV, and the new upcoming and senior doctors like Dr. Neha is also there. So we had an excellent mix of experience and youth of doctors over here, along with people like Dr. Manoj Pardesh, who has worked extensively in the community and has been fighting very strongly. He hilariously talked about killing billions of viruses, and that's a very good and I would say a motivating message when you take antivirals. I've heard in many conferences, like it's all about when drugs goes inside the body, it has to work. So again, a very important message. Like is one of the life example, I would say, in many of the cases which doctors have shared, that adherence becomes a very, very key important once you take the drugs. So this is another thing which again becomes very important for. I have been seeing some couple of cases very closely. They are in my distant relatives and all. Since they know I have been working in HIV segment, they do speak about their disease with me as well. So what is the key I've seen? That again, adherence becomes a very important thing. So what we have around more than 200 registrations and live participants who have attended this wonderful webinar. Yet another excellent moderation I have seen from Dr. Gilada sir. I've been listening to a lot of other programs on COVID and other subjects as well. An excellent moderation once again. A very crisp and excellent presentation given by Dr. Gogia sir. I have heard him in Delhi as well. So thank you so much for a wonderful presentation, Gogia sir. And what should I say about Dr. Bora sir and Milind sir? Both have excellent experience. I have been in interaction with them from last more than 16, 17 years in the time I have been working in HIV. So thank you for excellent contribution and practical experiences and sharing the experiences of a patient. And yes, I have been listening to Dr. Neha's presentation in various CIDS conference as well. And we are sure that the new patients and all patients in Delhi must be very happy to have an experienced ID physician in Delhi. Thanks for your presence too, ma'am. Thanks, Manoj, for your presence and highlighting both the social impact as well as in the social area which needs to be covered, the insurance factor. Because again, I have seen that too very closely when some of the patients which I know had to admit and they were not covered despite having insurance policies in the name. Anyways, sir, we had a wonderful evening, scientific evening, as well as the social messages were given. We had many patients also who were attending this along with doctors. So I thank entire faculty, all the panels for making this evening very, very fruitful. Thank you, everybody, and thank you for a wonderful session. And I can say that this webinar comes to an end, and we can close it officially. Thank you, everyone.
Thank you.
Thank you, sir.